Good morning. I'd like to call this meeting to order. It is the meeting of the Minnesota Senate Health and Human Services Finance and Policy Committee. It is Tuesday, March 10th, 2026, and we do have a quorum present. Our first bill on the agenda is Senate File 3612. Senator Marty.
Thank you, Madam Chair and members of the committee. And before I begin, I wonder, would you like to take, I have an A1 amendment, and I wonder if you would like to start with that. And yes. I'm happy to give a brief explanation. If so, it's author's amendment.
Sure. Senator Mann offers the A1 amendment. This is an author's amendment. Last year, we had informational hearing only on this bill. All those in favor of the A1, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Marty.
Thank you, Madam Chair and members of the committee. Senate File 3612, which we're calling a patient-centered care bill, would basically take our Medicaid and Minnesota care programs and eliminate the insurance middleman in the system. Several decades ago, Minnesota and many other states decided to contract with HMOs to administer the Medicaid program, which is in effect putting in a middleman function. Instead of paying doctors and providers directly, the state pays an HMO middleman who then would pay the providers. And the theory was that the HMOs could save money by managing care, though in practice, I believe what they're basically doing is managing their claims payments, not patient care, and in many cases actually interfering with the patient care. There are additional administrative costs and bureaucratic red tape from putting in an additional administrative step was apparently not considered. The program was never effectively analyzed. In fact, several decades later, we still call it a demonstration program that's never been demonstrated. And this proposal would eliminate that middleman for the two public programs because they create barriers to patient care, using limited networks, differing drug formularies which change, prior authorizations. The patient-centered care bill would not only eliminate the barriers, would also have real paid-for care coordination and case management from medical professionals in counties. Who should coordinate care? Who should deal with case management? It should be the people who work in that field, not giving an incentive to somebody else in the hope that they will somehow or another manage care. Second reason we want to do this is the lack of transparency and accountability in how the money is spent and how much the state should pay for the service. I'll go back 15 years for one illustration of how challenging this is. In 2011, one of the smaller MCOs, use managed care organizations or HMOs, I'm using them interchangeably. One of the smaller ones made a huge $30 million charitable contribution, one of the largest in state history, not to some worthy nonprofit or higher education institution, but to the state of Minnesota's general fund. Even though the state and the DHS didn't realize it was overpaying them, UCare thought it would be responsible to repay the overpayment. When accountability for a program is so poor that some of the contract recipients feel they should repay some of the excess they were given, we should be questioning why we have these massive contracts to manage our public programs. Again, these two programs, Minnesota Care and Medicaid, are paid virtually 100% by the public, either Minnesota specific or Minnesota and the federal government. Next reason is that the contracting rules under CMS requirements require actuarial soundness for rates paid to the MCOs, which means the state must cover all the costs the MCOs incur. And I'd say that includes not just their costs for health care and administration, everything else, but even the costs for fines and penalties and assessments against them. A fiscal note several years ago stated, and this is a direct quote, the cost of paying the penalty that was being proposed in the bill will be included in the health plan's experience in subsequent years and may result in higher DHS capitation rates, close quote. In effect, taxpayers are on the hook to pay all of their costs, even their fines. And finally, high administrative costs. When you add a middleman and additional level of administration, it jacks up the cost. The state Medicaid program had about a 4 to 5% administrative cost rate before we brought in the MCOs. Now we still have a lot of state Medicaid administrative costs to negotiate and oversee the program and so on, and we now have those costs plus the MCO costs, which are much higher than that. Connecticut is a state that dropped MCOs from their Medicaid program back in 2012, and they've had big savings from doing so. We have the speaker from Connecticut who will be speaking in a minute. And Minnesota is not the only state looking at that. At this time, I believe Illinois, Wisconsin, Indiana, Maryland, West Virginia, Missouri, Ohio, Hawaii, Iowa are all also looking at doing this because of the cost savings. I think every one of us, both parties, want to be good stewards of public money. That's why moving to a direct payment system makes so much sense. Not only does it save money by eliminating the middleman, but the reduction in complexity helps make it easier to be transparent and accountable, and we can focus more oversight on where we need to focus oversight. Eliminating transparency makes things more accountable. Real quickly, I'll mention how the bill would work. The bill would, over the next year and a half, would replace Minnesota's delivery and payment system for these two programs, which is basically a quarter of all Minnesotans, about 1.3 million people, with patient-centered care system. Under it, DHS would pay providers, clinics, hospitals directly for the care they provide to patients. The state would not renew the contracts with HMOs or IHPs for either Minnesota Care or medical assistance. The state would contract with one or more administrative service organizations, ASOs, to handle claims processing, but they couldn't shift any risk to them. They'd be simply doing the claims processing and a few other administrative things related to it, not a risk-based system. And on top of the payments for medical care services, Minnesota would pay primary care providers a small monthly fee. Patients would be encouraged to pick a primary care clinic, one that they actually use, and that primary care clinic would get a small monthly payment for that. We believe the people who should do the navigation and the help with care are medical providers, primarily at primary care clinics. But in addition to those payments, the state would be, DHS would be contracting with the 33 rural county-based purchasing counties, and it would be able to contract with other counties and other entities that could provide case management and other services. Again, the county-based purchasing systems have been doing a good job of doing a lot of this case management work, and we would have them continue doing so. But what we'd like to have is every county in the state and every patient having a system in place where they can make this happen. Among the types of other things, the commissioner would be having a 24/7 nurse hotline, which I think many state employees have through the health plans we have, but we'd have a statewide nurse care line. Among the 3 or 4 problems I want to make sure stress the things we would be benefiting from, it would eliminate that extra administrative step. And the state right now, I think sometimes people say, well, fee-for-service is a bad system where you pay people. Well, 98% of the economy works either a fee for service or a price for a product. We'd be doing the same here, and we actually have that. When we pay a capitated rate to a health plan, they largely pay their providers fee for service anyway, so we're just putting in a middleman step to pay that. Second one is, and this is one I really believe is important, and that MCOs are interfering with care. Even though we're paying 100% of the care, I can give you some examples of this. Health plans have limited networks, which increases already serious health inequities. They've disrupted the lives of patients. Several years ago, UCare was largely dropped from the Medicaid program, and Medica gained a bigger contract, which caused hundreds of thousands of people to shift providers, have to shift plans, A year later, Medica withdrew from the market, causing 300,000 people to switch coverage. A couple years later, they decided to be included in PMAP again, another huge disruption. Now UCare is gone completely. The disruptions continue. We wouldn't have that. And finally, again, when I said that this current system is not transparent and lacks accountability, I've heard over the last couple of decades, I've heard both Republican and DFL legislators refer to the lack of transparency, calling these MCO contracts as a big black box, something you can't see into, you can't see what's happening. We've had problems with that. I'd be happy to go into more details on anything, but maybe if you're willing, Madam Chair, I'd love to have the 2 witnesses I brought. The first one is online only.
Thank you, Senator Marty. Yes, we can go to your first testifier is on Zoom, and Sheldon Taubman. And if you could please state your name for the record and begin your testimony.
Thank you, Madam Chair. My name is Sheldon Taubman. I am an attorney currently with Disability Rights Connecticut, although What I'm going to testify about today concerns mostly a period when I was at New Haven Legal Assistance in New Haven, Connecticut. In 1995, we rolled out capitated managed care initially with 11 entities, mostly for profit, a couple of nonprofits. At the time, we were promised that this is going to save money. That was the real reason it was done. And to make sure that was going to happen, we were told that after the first year, they would be paid basically rates that equivalent is how much the state was paying for Medicaid under fee for service. But that after the first year, we will drop to 95%. So by definition, we're going to save 5%. And I should say that never happened. It was also said that we're going to a broad provider network because that's what people complain a lot about. And some of the companies also have commercial products, and they said, we'll have all the same doctors. Yeah, that wasn't true either. The ongoing problems were extensive, network inadequacy, excessive prior authorization, and seemingly red tape for the sake of red tape, non-compliance with due process, meaning when services and goods and services were denied, lack of written notice that tells people what happened, why, how they can appeal, high costs. So remember, we're going to drop down to 95%. That never happened. And then instead, it kept going higher with the MCOs. And as the number of MCOs dropped, they had more power, demanding more money if you wanted to stay in. And maybe overriding all of this was a lack of transparency. So it was really hard to get medical loss ratios, provider rates. We remember there's a problem of lack of adequate providers. So what's the reason for that? Big question is it because they're paid too little, right? And so we couldn't get those rates. That is to say, they claimed it was proprietary. They always claimed they were doing it better, they were doing it cheaper, and only they could coordinate care. On that last piece, we never saw evidence that it was happening at all, let alone it didn't make any sense that only they could do it, but they were not doing it. I think the senators referred to, not managing care, managing costs, and that's basically what they were doing. So we had to do a lot of work. This is a long period. This is over 12 years. You don't do anything like that in Minnesota. But over 12 years, we found that they did have very low medical loss ratios, meaning a large portion of the dollars were not going to health care. And in the case of the commercial ones, they bragged about their low medical loss ratios in their calls with investors. We also, other people organized a secret shopper survey, which was a very well-designed study to see, can people get appointments or not? And it was horrendous. It was around 25% of the time only could people get an appointment for a variety of different kinds of providers for all the MCOs. At that point, we had 4, because all kinds of reasons were given, but these were the providers listed by the MCOs on the website as current providers, and 25% of the time, at best, they could get an appointment. We also found evidence of basically fraud, which is to say the MCOs were denying services and saying to consumers, sorry, that's not covered under your plan. That's not covered under contract with the state, which wasn't true. And one example of that is at the pharmacy when drugs were denied because you didn't get prior authorization, which was imposed extensively, they chose the code to say to the pharmacist the drug was not covered, when of course it was just requiring prior auth, which was another available code, but they didn't use that. They used a code that said something false. One of the last things, this is a very long saga, so as we get to the end of it in 2008, 9, in this period, we found that they were being paid over what the senator referred to the actuarial soundness of rates, that an auditor came in and found that what was approved was excessively high rates. And maybe that's because of all the years of demanding higher and higher increases. But after years of fighting this, the state did take back the risk. It was announced by the incoming governor at the time, Daniel Malloy. 3 weeks into his being inaugurated, it was his first major policy decision. He said, we're taking the risk back. We will be contracting with administrative service organizations, ASOs, on a non-risk basis, and we will be extensively using patient-centered medical homes, something we've been advocating for, so that there would be true care coordination, something MCOs always claimed but never did. We want to see that because that can really improve care and save money. And so the whole process was announced in February of 2011, was completed in January 2012. During that time, we did a full RFP process to get ASOs for the three big areas, medical, behavioral, and dental. We got them. And interestingly, the biggest one, the one for medical, was a former MCO. It was the one nonprofit, homegrown MCO, took the role from being a risk basis, paid on a risk basis, to being the non-risk ASO. So it does prior authorizations, as do the other ASOs, but critically, no thumb on the scale. It doesn't come out of their pocket. If they approve of services, they don't gain anything either way. And that has worked very well. Since the conversion, it's not perfect. We have issues, of course. We have still fights out in the open about low provider rates, but we've saved billions, like at this point over $4 billion. We're a tiny state. We have very high medical loss ratios, around 97%, meaning almost all the taxpayers' money is actually going to healthcare, very little to administrative costs, and that includes the significant contracts with those three ASOs. We're doing better on quality measures in most states. We have real care coordination, and I should say not just through patient-centered medical homes, which we pay extra for doing that, but also the ASOs have an intensive care management responsibility, which they discharge for patients that are having issues, frequent flyers in the emergency room, whatever. So you have sort of two different places where care coordination is going on. We also, since the conversion, have much higher participation of providers. And I want to stress, both for primary care and specialists. For primary care, that could be explained by higher payments, because a year later after the conversion, we did increase provider rates pursuant to the ACA, and also there's some additional payments as PCMHs. But specialists received no increase. And despite that, 19% increase in specialist participation. We believe that's because the prior authorization grief was dramatically reduced, and something really basic. People could get paid in a timely way without having to pay special companies to fight with the insurers, because it was now the state responsible for it, and it did it in a professional way. That ultimately saves money for providers, even if their rates don't go up. And lastly, I did want to mention that, we've had this system, which we're very happy with, for since January 2012, so it's been 14 years. But an issue came up in 24 about how come we're so different, right? Most states have MCOs, why don't we? And so the governor asked this question. The state contracted with a consultant to look at it, and I will tell you, the consultant chosen is an entity that serves and even represents MCOs as well as Medicaid agencies. And they found, after looking at this is the report in December of 24, I'm happy to share it with you, found that Connecticut has 14% lower overall costs than the other states in the Northeast, most of which use MCOs, and that we have much lower administrative costs, as I mentioned, and that we're doing much better in quality measures. So after that report came out, people felt that was, considering the source, confirming that we made the right decision back then. I will say that in Minnesota, like everybody, we're facing the cuts from H.R. 1, which are very serious. We don't have an option of going to ASOs to avoid the costs, to save some of the money, but you do because you have MCOs. And so some of the cuts under H.R. 1 in terms of federal reimbursement could be addressed by cutting out the middleman and saving a lot of those administrative costs with the MCOs. Thank you, and I'd be happy to answer any questions.
Thank you. I appreciate that for your testimony. Let's see, we can go to your second testifier, and Nancy Westman, if you could please state your name for the record and begin your testimony.
Sure. Nancy Westman. Good morning, Madam Chair and members of the committee. Thank you for allowing me to talk with you today about my experiences. Again, my name is Nancy Westman, and I'm a psychiatric nurse practitioner. I have provided psychiatric care at all the various levels for over 40 years. This has allowed me to witness the changes in the quality of care as Minnesota began to privatize around 1996 versus having it direct paid through the state. Over my time, as I was practicing, and my colleagues and I have noticed the growth of barriers to providing necessary care. What we call barriers or obstacles, the HMOs call strategies to reduce volume of services and cut perceived costs. However, there's no actual evidence that reducing volume has cut costs, and there's no interest in actually any effort to really look at the cost of care. But I'm here to discuss the perspective of how these strategies are actually obstacles to quality of health care. I'm going to start with a couple of examples, and then I'm going to summarize these examples more specifically. I can tell you a story about a 12 to 13-year-old male who came in my care about a year ago for about a year. And he presented to me with acute mania. At that time, he had never had formal evaluation. He clearly had some issues with cognitive intellectual functioning. He was already in a level 4 education. Clearly, there was some indication through the school system that he needed that care level of academic support. And so I immediately tried to work with our clinic coordinator, a new role because we spent so much time doing case management without being reimbursed. And she assisted this patient to try to get some county case management services. I will tell you that many of our patients, we are told that we can't go directly and refer to county case management services for mental health, and that it has to go to the HMO first before it can be approved, and then they will refer for county case management services. And then when our patients will go to the HMO, they are told, oh, what's your address? We're going to send you a list of resources in your community. That is not case management. These are chronically and persistently ill children, adolescents, and young adults, and they send them something in the mail, and that's it. We eventually, for this particular person, were able, after over 30 phone calls to the county by this coordinator in our clinic, able to get someone to be assigned to this case. And even with that, on one occasion, the father missed one phone call and didn't get back to her, so they dropped him, and he had to start back over in the process. These families are also struggling with multiple jobs, and they have their own vulnerabilities, and they're trying to do their best. Missing one phone call should not drop you from being assigned a case manager and then having to start over on the wait list. So despite continuing with case management, like with our case manager or coordinator helping this patient stay connected with the county case manager, despite continued medication management over time, he eventually did get one about 10 months later that stayed with them, I think, but then all of a sudden they stopped coming to our clinic, and we gave them lots of opportunities to come in. We tried to reach out, offered to go to the home. We did all kinds of things. Due to policy, they were transferred to another clinic, and what I could see in the documentation, there is no case management. They are at their new clinic about a month later, but in the meantime, they've been suspended from school multiple times due to their mood behavior dysregulation. They've eloped due to their illness and cognitive disabilities. They have been in the ER at least 3 times due to dysregulated behavior, but they never get admitted. They sit there for about 24 hours, and then they're sent back home because they're sedated. They say that they'll do what they're supposed to do, and then here we go, it's another cycle all over again. This is not case management, and mental health and psychiatry clinics do not get case management. Primary care clinics may, and when we try to engage them to help us with the mental health case management, they're not trained. They have no idea what the resources are. We need case management in mental health and psychiatry. So I hope that illustrates some of our issues. So one of the way HMOs try to reduce costs is by limiting network choices, limiting formulary choices, or having to jump through hoops. I may have to trial 3 different psychiatric medications to support and stabilize a patient while they're having side effects Their labs are abnormal because I can't get the one that isn't covered until they at least tried 2 and failed. It's ridiculous. This leads to unnecessary delays and denials and needed interventions. Patients cannot pay out of network for providers that we may refer to, procedures or medications. Procedures include appropriate psychiatric evaluation and neuropsychiatric evaluations or neurology consults. These children have neurobiological conditions. Decompensation leads to costly higher levels of care as they continue to decompensate with inadequate care. In some cases, patients get hurt and even die. We have had patients that have tried to kill themselves and have landed in the ER for weeks and months trying to recover from their injuries. Another major obstacle is the lack of real case management, which I already elaborated quite a bit on. At this time, case management, whether done by the provider or clinic professional, is not reimbursed. This is all in our own time. We spend time calling and documenting, working with teachers, counselors. We try to work with child protection. None of this is reimbursed for us. While patients, all during this time, patients may be referred to case management services, but as you can see, they're practically unattainable. These case managers through the county clearly are underfunded, understaffed, and they're burnt out. And there's a lot of turnover. Furthermore, I hear from my colleagues that work in HCOs that they feel the constant pressure to reduce the quantity of services. Don't order that lab, don't order that consult. Procedures and other necessary consults, even if warranted for patients' need, are held off on. They are provided an incentive or bonus if they stay on budget. This reflects that the value of keeping on budget is much more important than the quality of care. Can you imagine the cognitive dissonance of working in this environment? Lastly, the amount of micromanagement required by the private industry is an obstacle. This includes excessive documentation to validate reimbursement for that particular service, or excessive documentation supporting a particular medication, procedure, or steps before they can get authorization for that procedure or medication. Having to do these actions constantly implies that we as providers are incapable or not competent enough to make evidence-based, individualized treatment plans for our patients. In addition, it assumes that the patient's problems are not important enough or bad enough yet to warrant a particular treatment. This only leads to demoralization, not only for providers, but also for the patients. They feel highly discounted and invalued. Thank you for this opportunity to talk with you today.
Thank you very much for your testimony. Senator Marty, there are 2 more people who would sign up to testify, and I'd like to go through those, and then we can go to questions. First, I'll call up Daniel Trujano. Welcome to the committee, and please state your name for the record, and you can begin.
Thank you so much. Daniel Trujano, Savage, Minnesota. Thank you, Chair Wicklund, committee members. I'm Dr. Daniel Trujano. I live in Savage. I'm a retired primary care physician and previously served as Population Health and Quality Vice President and Senior Medical Director for various Minnesota nonprofit healthcare systems and health insurers. And I currently teach part-time at a local university, healthcare economics to MBA students. And for full disclosure, I also serve as a board member for MNsure, but I am not representing MNsure with my comments today. And I am testifying in support of SF 3612, the Patient-Centered Care Program. So throughout my career, I have worked to improve healthcare by aligning payment with better outcomes, improved service, and stronger care coordination. And in principle, I support moving away from our current sort of sick care payment system toward a model of payment that rewards better care coordination and keeping patients healthy within their chosen healthcare provider system. However, relying on multiple insurance companies to design separate payment models, each with its own reporting requirements and multiple different quality metrics that burden providers has created this enormous administrative complexity. And in many cases, that approach actually does just more harm than good when you're trying to practice medicine. So hospitals, doctors, nurses, staff, today we face the burden of tracking and reporting hundreds of different quality measures across numerous insurance programs. And this contributes to rising administrative costs, growing provider burnout, and most importantly, it takes valuable time away from caring for patients. So I believe the most powerful thing that we can do to improve the healthcare system is simple. Let our doctors, our nurses, our providers spend more time with patients and less time reporting to multiple insurance companies. And I believe SF 3612 is a step towards making that happen. And I thank you for your consideration.
Thank you. And last, I have Chelsea Olson. Welcome to the committee, and if you could please state your name for the record and begin.
Thank you. Madam Chair, members of the committee, my name is Chelsea Olson with the Minnesota Council of Health Plans, the trade association representing the nonprofit health insurers in Minnesota. It's a Blue Cross and Blue Shield of Minnesota, Health Partners, Medica, and Sanford Health Plan of Minnesota. Thank you for the opportunity to testify today with our opposition to Senate File 3612. The most important question that needs to be answered on this proposal is, will the lives of the over 1 million Minnesotans currently enrolled in managed care be improved if the current managed care model is eliminated? And we contend the answer is a firm no. The managed care model provides several significant benefits to the state, but most importantly, it improves health access and outcomes for Minnesotans enrolled in Medicaid through care coordination services provided by the MCOs and guaranteeing access to providers through leveraging commercial networks. We appreciate that this bill recognizes the value of care coordination, but we are concerned whether providers are ready to take on this work that is currently performed by the care coordinators with the MCOs. Council Health Plans currently have well over 1,000 care coordinators to help Minnesotans access the care they need and who are specifically assigned to each member to ensure enrollees do not fall through the cracks. MCO care coordinators proactively reach out to members to ensure they are receiving vaccinations, making their primary care visits, helping to arrange transportation, interpreters, and daycare before a visit. They also help track chronic conditions of the members. Under Senate File 3612, providers are tasked with coordinating care. We know there's a serious shortage of primary care physicians, and most Minnesotans do not have a steady primary care provider. This bill would fragment care coordination with no one assigned care coordinator for each enrollee. Senate File 3612 is also missing language to ensure accountability. Health plans are subject to a 5% performance withhold for quality, ensuring that there is a financial penalty if enrollees do not get the care that they need. This bill is absent of any similar type of accountability. We are also concerned that without accountability, providers will not accept MA patients. Prior to managed care, providers were actively choosing to not see MA patients or to only serve a limited number because of low MA reimbursements. In one county, it got to the point where there was only one OB who would provide birthing care to women on MA. Today, managed care organizations leverage their commercial contracts and require in-network doctors to see patients on both their commercial and MA lines of business. How will the state replace this leverage to prevent providers from prioritizing commercial payers over the lower-paying MA enrollees? The reality is that a similar impact is already seen in the MA dental program, where enrollees struggle to get appointments. Beyond patient concerns, there are a number of financial benefits to utilizing an MCO model, and ending this program will have financial impacts to the state budget. This includes a financial shift carried by MCOs, and MCOs holding on to financial losses in the MA program. Just yesterday, the Program Integrity Director, Tim O'Malley, testified to the partnership opportunity between MCOs and the state, saying that MCOs have a vested interest in preventing fraud. This bill eliminates that vested interest. Ending managed care could also invalidate Hennepin Healthcare's directed payment program and the state's waiver for the Minnesota Care program, both which run through the managed care model. Under this bill, these programs may end. Thank you.
Thank you for your testimony. Members, I'd like to open it for questions or comments. If there are any. Senator Utke, is that? No.
Thank you, Madam Chair. I'll start off here with a couple, but as we look at this, it says that DHS will pay the doctors, hospitals, pharmacies directly. How large of a department, or, I mean, this is going to be another agency within an agency, so to speak. How do we envision that working? And, I mean, currently we have multiple insurance companies and the whole infrastructure in place that's taking care of this. And now all of a sudden we're going to say, or propose that an agency takes care of it.
Sure.
Senator Marty.
Thank you, Madam Chair. Senator Utke, first of all, you did mention, yes, there are multiple insurance plans, all having multiple bureaucracies within them. What we would be replacing it with would be the state would be paying the bills, and we'd have an administrative services organization to deal all the claims payments, some of the complaints, things like that, the routine things about paying the bills, making sure they're going to the right people at the right time. And that's by taking the risk out of it. In other words, frankly, there is no risk in the current system because we have to pay them basically all their expenses, as I mentioned, even penalties. But what we'd be having is, instead of, I presume one of the existing MCOs, which already deals with claims payment, would continue that part of their business. They'd be dealing with the administrative paperwork for all of that. And that's important to have a good, efficient system for that. We are not envisioning, the bill would allow the DHS to contract with one or more of these ASOs as they see the best way to administer care in an efficient way.
Senator Utke.
Thank you, Madam Chair. I guess I'll go back at it a little bit at a different angle, because first of all, when we talk about starting up an agency, I just think back to the one that just started up this last year, and that paid family medical leave, and how many people that took, and the $2.5 billion or whatever to start it up. So I think there's a lot of things here that aren't being talked about, but let's just go right back to the basics. You've had bills like this over the years. I noticed that this one is just introduced this year, but is there a fiscal note that's relatively close? What do those numbers look like?
Sure. Madam
Senator
Chair, we are
Martin.
awaiting the fiscal note right now. The department, as you know, has got lots of fiscal note requests right now. We are awaiting that. The one thing I want to point to about this is we have, Mr. Taubman pointed out in Connecticut, even though they're doing all the case management, the care coordination and so on, I think he said there was like 14% savings. When we're talking, I mean, Medicaid is basically, Medicaid alone is close to, I think, 18, 19 billion a year for the state when you count both state and federal money. 14% reduction is, we're talking real money. And that's after they're doing it. Connecticut, by removing the health plans, they all of a sudden are still doing the services. Actually, they're paying directly for case management and care coordination instead of turning it over to somebody who says they have the incentives to do it right. And they saved, unlike when they moved the other direction where things were supposed to go down in costs, and he testified how they went up. We've had the same thing with it continuing to go up and up and up, much faster than inflation. To me, getting rid of some of that extra administrative costs makes it simpler. And frankly, I think one of the reasons you find so many providers in the states that do that, liking the new system better, is because they don't have the administrative hassles. And as they say, they have to, as Ms. Westman said, they have to deal with each insurer for the formulary, for everything else they have to do. Everybody's got their own regulations, their own everything else. The paperwork that they're not spending time on patients with, replacing with a much simpler system. So I think it actually should, one, save a lot of money and have a lot less administrators, and two, have more people doing actually care, which is what we want to have. It makes people healthier and frankly saves money.
Senator Utke.
Thank you, Madam Chair. I do have another question or two, because the first one is probably more of a comment, but we talk about the managed care organizations, and coming from rural Minnesota, we see how valuable and the asset they are to full care for our citizens. If they don't spend it all on health care as far as going to the hospital or clinic, they're involved in standing up dental clinics and everything else that can serve this population that's on MA coverage. So that's the one thing I always caution people on is they do so much good and they use every dollar to the max as far as providing care of all kinds across the board. So I hope that, we keep that in the conversation too, as we look at if we're saving, what are we cutting? And then, it comes to, I had heard the comment from I think it was the first testifier on Zoom, just had covered the fact that the reimbursement rate to providers sounded like it might have been less. How do you see that here? Because we already know MA rates are not good. In fact, they're horrible. There is no room to make it any less. So has that been part of the conversation and part of what you envision here? Because if we're going to tell our providers, well, currently they get maybe 65 cents on a dollar for their costs, and we're going to say you're going to have to live on less, I don't think that's going to work, and we're going to lose providers. So that's just the kind of the way I see it and some of the concerns I have. So thank you.
And Madam Chair, one quick
Senator Marty?
comment on the end of that, and that is as Mr. Taubman mentioned, in Connecticut, they had both more primary care providers, which there's the biggest shortage of, partly because they were paying them more, but also they said even when they didn't increase provider rates for the specialists, they had an increase in specialists. And part of the reason is even if you don't make any change in their reimbursement rate, if you take away all the administrative hassle. Last week during Minnesota Medical Association Day at the Capitol, I had a young resident at a family practice clinic. I think she said it was in St. Paul. She was there. I asked how many. They said 19 doctors or residents in there, and they had 4 people just to deal with the prior authorization things. 4 people for 19 providers because they have so much administrative time. If you take away some of those extra costs, then if you're paying the same rate for the services, it's actually it's a pay increase for the providers. So that's why I think we have the burnout we have of physicians and nurses and other providers here. And I think why Connecticut found an increase, which is what we'd expect.
Thank you. Senator Fate.
Thank you. Thank you, Madam Chair, and thank you, Senator Marty, for introducing this legislation. I have just a couple of quick questions. I believe the testifier from the Minnesota Council on Health Plans had concerns around, I think she said, accountability. What level of accountability or transparency is there with the current model with the HMOs?
Senator Marty.
Madam Chair,
Who are they
Senator
accountable
Fate.
to, I guess? Or I guess who are they accountable to? Who are they accountable to?
Well, to me, the problem we have right now, and one of the many problems we have that relates to so much waste and misuse of money and so on, is the complexity of the system. Who's in charge of this? I mean, the audit that was done recently of the human service programs, they looked at only the fee-for-service ones. They didn't, they should look at that. But they should also be looking at the managed care ones. And the point is, the health plans always say, well, we've got the incentives to do this because every dollar is wasted, we don't get the money. But the way it works out, we have to, the actuarial soundness that CMS requires, we have to pay all their costs. So if they have more wasted money or if they have anything else, we have to pay the costs. The rates go up the next year to cover them. We've been having that do it constantly. And to me, this bill, what we're trying to say is that not only does the DHS and the fee-for-service stuff have to have all the accountability, but we are also opening the door with transparency requiring the ASO. We specifically say that they have no proprietary interest in the data. It's all accessible to the Inspector General, the legislative auditor, everybody else, because we want to make sure every part of the system is open for accountability. And right now, we don't know how much is going for it. We don't know what the rates are.
Senator Fate.
Thank you, Madam Chair. I had another question. I forgot the testifier's name. She was a psychiatric therapist, I believe.
Ms. Westman?
Yes, please. May I call her for a quick question?
Sure. Ms. Westman, could you come and answer a question? Senator Fate.
Thank you so much, and thank you so much for coming back up. I wanted to see if I heard correctly during the testimony. I tried to take a little bit of notes. Did you say that in your profession that you are required to essentially, when you're coming up with a plan for a patient and you want to provide the medication, that you're required to fail twice, trial 2 medications first, and then provide them, even if you know what they actually need? You might have seen this case many times before. What could be the reason for that? Because I'm only seeing a financial incentive for that kind of situation.
Ms. Westman.
I guess I can only assume the same as you, that the PBMs, pharmacy management entities, will do what they can to lower the cost for the HMO by preferring certain medications that are cheaper for them, or that they may have a contract with the pharmaceutical companies. That's all we can get. It's just a way for them to save money.
Senator Fate.
Could I also get a response from the Health Plan Council testifier around that answer?
Ms. Olson, if you can.
I apologize, I forgot your name as well.
My name's Chelsea Olson.
Senator Fate, the same question, did you say?
Same question.
Ms. Olson, do you need the question repeated? Or
Would you like an answer around accountability as well as the fail twice protocols?
Sure, thank you.
or Ms. Olson.
Thank you. So around accountability, health plans are required to submit every single encounter data that we have with a patient to DHS. DHS is aware of all of the claims paid out, all of the visits that we see, and there are also withholds that are built into our contracts, a 5% quality performance withhold, so that if we don't have infants in for their vaccinations, if we don't have people in for their annual checkups, if they are missing different health metrics, then that part of the contract is withheld. And so there is a financial incentive to ensure that patients are receiving the best care possible. In terms of why there are provisions like utilization management and requirements to try perhaps a less expensive drug, is health plans are one of the only actors in the market that help try to hold down the cost of care. So if there are drugs that have been shown that may be just as effective but less expensive, oftentimes an insurer may try to have an individual use that first to ensure that they are able to use the least costly medication.
Senator Fate.
Thank you. And then back to the former testifier. So what I'm hearing is that you're required to use or trial medication that is either identical or similar, but is that what you're experiencing also in your profession?
Ms. Westman.
That may be what the prior authorization is asking, but we know more details about the patient individually and what their needs are. Perhaps they cannot swallow a pill and they need the liquid formulation. Perhaps they have oral sensory sensitivities or on the autism spectrum or something like that. They may be obese and have liver disease at a very young age. We need to look at the medication with the least metabolic side effects before we try 3 other meds. So we're looking at the big picture and what's best for the patient.
Senator Fate.
Thank you so much, Madam Chair. I'm good now. Thank you.
Senator Port.
Thank you, Madam Chair. Thank you, Senator Marty, for bringing this bill. I have spent a lot of time in the healthcare industry over the last 5 years, and because I spend a lot of time there, I talk to a lot of people. I talk to other patients, I talk to providers, I talk to nurses, I talk to doctors, and I spend a lot of time on the phone talking to my insurance company. And, you know, I'm hearing here, and I think we always hear this drumbeat of the purpose of these MCOs and insurance companies and PBMs is to lower costs, streamline services, sort of make everything a one-stop shop. But more and more what I am hearing from patients is, and my own experience and many others, is time spent on prior authorizations for the care that their doctor knows that they need. You know, a limited list of providers. You can't go see the doctor of your choice. You can only go to these in the network. Difficulty like navigating the black box. I know for myself, like I have a whole team of people here who I can ask questions from, and it was nearly impossible for us to navigate me getting my first like real care for long COVID. And it's a labyrinth for regular people who don't have these resources. And then I hear from doctors and nurses that they don't get to spend enough time with patients. They are spending all this time on admin. They have to fight to get the treatment that they want to give their patient, that they know fits their patient, and that their patients need. And instead they're spending this time arguing with a middleman, with an insurance company who's trying to limit the cost of care, I guess. But over and over and over, I don't see how it's working. We've been trying this for decades. And every step of the way, we keep this like idea of this industry that we need in order to make our medical system work. And it is less and less and less connected to care of patients than I feel like it ever has been. I'm not surprised that doctors are leaving the profession. I'm not surprised that nurses are leaving the profession. When they are understaffed, they're not allowed to have enough nurses on staff. The patients don't get the time that they need with their care providers. It is no surprise to me that medical professionals are leaving. And it is no surprise to me that patients trust the system less and less than we ever have. I don't know how we fix the whole thing. I think it's a big, huge problem of rebuilding the whole system to be patient-centered. But I do think that this is one step. And we're already doing it for 250,000 patients about. Like, it's not like we don't know how to do this. We do. And we know from other states that it saves money. And so for me, the only thing that sticks out here as a reason why we haven't done this, why other states haven't done this, is because there is a very effective and expensive lobbying power against this. And patients don't have that same power. But they are getting sick and tired of being the last thing on the list when we think about care. We talk about health insurance a lot. We talk about health coverage a lot. We don't get to talk about health care very much. And I appreciate that this bill is centered on that, Senator Marty. I think it's really important that we put patients first as we're having this conversation. I think this is a complicated problem, but this is a really smart first step that we can take to move us in the right direction. I know you've been working on this for years, and I appreciate your continued willingness to evolve on it, but I think you have a really good bill here, Senator Marty, and I think that Minnesotans deserve patient-centered focus for the first time in a while.
Thank you. Senator Bolden.
Thank you, Madam Chair, and I can't say it any better than that. Thank you, Senator Port, and thank you, Senator Marty, for bringing this bill. I appreciate all of the years that you have put into this issue, and I appreciate this bill. I appreciate that it is I think the name is exactly right, the Patient-Centered Care Program, and we do need to redirect our healthcare system to put patients at the center. I too, like Senator Port, spend a lot of time in the healthcare space, both with my professional hat on as a nurse, but also in my personal life, as I have a son with complex medical needs, and I too navigate the labyrinth of care for him and have never received care coordination from an insurance company, but I do spend many, many hours on the phone with an insurance company, fighting, prior authorizations that have been denied, trying to just navigate to get him the care that he needs, as do thousands and thousands of Minnesotans. As I talk to people about their health care, it is very clear for Minnesotans that if you have a chronic health care condition, if you have a disability, that is at best a part-time job to navigate our healthcare system. At worst, it's a full-time job or more, or you just don't get the care that you need and deserve. And so, and as I talk to patients, the amount of time that they spend, again, navigating, trying to get the care that they need, making phone calls, trying to fill out forms, trying to figure out, can I see this person? Can I see that person? I'm going to be discharged from the hospital and I need further care, but it's not covered. So how, who is going to come and help me to take care of myself in a time when they should be recovering and, getting well? They are having to worry about all of these other issues and navigating how are they going to get the care that they need. And so I heard one of the testifier from the health plan say that they are worried about patients falling through the cracks. I'm here to tell you there are deep chasms that patients are falling through today and have been for many years. And so there are absolutely steps we need to take to have a system that is centered around care for patients, and I think this is the next one. It absolutely makes sense to me to take out the middlemen, to ensure that we are directing funds for care that patients need. And so I just want to thank you for bringing this bill, and I hope we can move this forward because it is in the best interest of patients.
Senator Port.
Thank you, Madam Chair. Just one more thing I wanted to say that Senator Bolden reminded me of. And one of your testifiers talked about this to fail program as you're not bad enough yet. You're not sick enough yet. You're not close enough to dying yet. And I think that is, it is so real for patients. I know when my doctor prescribed the first treatment for me that she thought would actually help, they told me that it was would be medically beneficial but was not medically necessary. I don't know what that means. I legitimately have no idea what that means. But it was very much, well, you're not dying today, so we're not going to give you the more expensive one. And the 2 trials that I had to go through for meds that were not what my doctor wanted me on, that process took 2 years. So it's not like this is, you're on it for a week, nope, it doesn't work. You're required to try it for a specific amount of period, a specific period of time, and then can you get another doctor's appointment? Can you get in to get the blood tests you need? All of these pieces take time and effort, and that is time that in many cases, patients are in pain, they are sick, they are unable to do their daily lives, care for their kids and go to work. And it is not just the cost isn't just this medication costs 30% more. It is what is the cost to that patient's life? What is the cost to that patient's ability to be with their family and, experience life as they should be able to? So I think that piece, just you're not bad enough yet, reads so true and is just a horrifying piece of how we think about medicine.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Marty, as you know, me being a healthcare provider myself, I've been trying to interact with you on this very issue on a regular basis. This is This is a provider, patient, and health insurance issue. I think the amount of red tape has become a burden on everyone. And we, of course, are now facing decisions that we probably never wanted to get into in the first place. I don't think when HMOs, MCOs, whatever you want to call them, when they were originally designed, that we ever imagined that this is where we would end up. And I can speak to that from a provider's perspective and a person who has to do the billing on the backside. You know, I'm not just a provider in a system. I own my own clinic, and I get to see that paperwork on any given day, and to have to deal with the interactions of, you didn't cross the T here, you didn't dot the I there, so we're going to deny your claim, and you're going to have to try again. The problem is it doesn't just happen with the HMOs or the MCOs. It happens with Medicare, and it happens with the state of Minnesota. No insurance provider, for whatever you want to call them, whether it's the state program, the federal program, or the individual markets, they all do the same thing. And so I'm not sure that this will solve that problem, because at the end of the day, we're still ending up with having to bill somebody. And we still have somebody telling us whether we can or can't do something, or how we're going to be doing it. And now with this program, unfortunately, I see it and go, this is going to be a lower reimbursement rate. This, it's your goal isn't to have that, but we heard testifiers even admit that sometimes the reimbursement rates will be lower than what the affordable area would be. I've had providers, MCOs even, say, well, we can't renegotiate your contract. From 2017 to today, they're paying me at rates that are from 2017. Well, I think we all know that inflation has happened since then, no matter who you want to blame for that. And the reality is the cost of living has gone up a lot since 2017. And guess what? I'm still stuck on a contract from 2017. And so with this, how frequently would those rates be renegotiated? How frequently would that be? Part of the solution is talking about what's the cost of living for a provider, and how is this going to be interacting with that? Sure. As you know, I think we've discussed, we both have different issues as to what we think are problems, and I would agree that the red tape is probably the area you and I would agree the most with. We've got prior authorizations, we've got managers that don't ever see a patient, that tell the providers who and how and when they can treat a patient that they've never even interacted with. We just heard testimony to that. And I agree, right? I have patients that I've been told, well, you can't treat that patient any more times because you've crossed a certain threshold. Well, do they know my patient? Do they understand that this patient's suffering from osteopenia and has issues with joint pain on any given day, and that the reason they come once a week is because that reduces their pain level by 60 to 70% any given week? And so, of course, they come on a regular basis. It's not what they want to do, it's what they have to do in order to feel even somewhat normal. So I don't know that this is 100% the perfect plan. I think there's some holes in it. I worry with a single option where you run into a market where the market's going to be even less negotiable than what we currently have. And that's the problem that I have with it. Because of course now if I'm only negotiating with one payer, and that payer thinks of me as a small individual clinic, which they will, they all do anyway, they're not going to refuse to negotiate with me anyways. So now I'm not even able to have that competition of, well, hey, I can go to Blue Cross instead, be a network with them. Again, I don't like the networks either. We've talked about that before, hence why the universal access plan or the reference-based pricing model we've offered is a possible solution as well. I don't think that it's a perfect model either. I think it has a lot of work to do, similar to this one. But I think if we work together, we're going to find a result that we're looking for.
Thank you. Senator Curran, did you wish?
Thank you, Madam Chair. And Senator Oski did a pretty good job at the summary of literally everything we talked about and every one of us experienced in the healthcare system. Pre-approval, pre-authorization, I can't prescribe who, what, and where, who works for us, and I think every one of us has experienced that. But you get to the mandates that were put on every level of the healthcare system, from the providers to the insurers, that won't change. Those will just shift. It'll shift into an unaccountable government. They still have to make the decisions on from a utilization, and yeah, that's about who uses what, at what cost, frequency, all of those things come into play. Senator Liskey talked about it. It may be frustrating, but he has a choice. With the government, you won't have that choice. You won't have anybody to even arbitrate, have a conversation with. And there won't be a position, we won't be in a position to have an unlimited ability to just cover what every doctor thinks is right. How will we guarantee that all of them will then even accept Medicaid, Medicare patients? We have a large healthcare system today. You're gonna require them to accept the same utilization as everyone else down in Rochester from Medicaid and Medicare. Don't see that in here. I don't think that will change. But really the track record, when we talk about even approved billing, who does that analysis, right? Even today, our healthcare plans are prohibited by law looking, how do we have better utilization, right? They're prohibited from doing those things. And if the mandates are gonna be suddenly eliminated or reduced because now government's gonna be in the middle, why wouldn't we do that for the current providers today? So I think the real challenge is we don't have a government, especially Department of Human Services, that is proposed to manage these actions. They literally have no corrective action in government today at any level when they fail. We see it today in group homes. We see it all across. Every one of us deals with those. The same heartache and poor outcomes and our elderly and our disabled living in neglect, because of the people who are managing it. They're good providers. They're all private sector providers for the vast majority, but we pile on the rules by people who have never done the job. Senator Liskey talked about some manager making a decision who's never seen the patient. Now you're going to have people who've never been in the medical industry making those administrative decisions buried within government that, for the most part, are inaccessible. Private companies have a need to answer that phone. It may be cumbersome, but we've created the entire problem. I don't think government being inserted in the middle is ever going to be able to provide us an opportunity that's going to function at a higher level at any administrative function, and then the customer has no choice. And so I think if we're going to eliminate the burdens or somehow do that, I think our current network is going to still do, even with all of its warts, far better than any government-run healthcare system, period. So I don't have any embedded question in there. I think we've had this dialogue multiple years. We need a wholesale change in it, but I don't think this is it. Thank you.
Thank you. I don't see any other members wishing to speak. Senator Marty, I won't go through my and emphasize some of what the other members have said, but for me, the administrative burden that patients are experiencing has really become just untenable, and I think it's important that you're bringing this bill forward so that we can discuss whether this way would be a way to incentivize the type of care that we're looking for and relieve some of the burdens that are falling to patients when they should be at the center, as you say. And we should be expecting to find ways that we get better health outcomes rather than just meeting the needs of entities that have to do this administrative work. It seems like the tables have turned too far towards that. So I appreciate your bringing the bill forward. We do need, obviously, some information about the fiscal impact and how we could make this transition, how much it would cost to do the transition work, and how can we demonstrate that the transparency and the accountability that we can gain will, save us money. And for today, we do want to lay the bill over to get more information, but I'd like to offer you a chance. Would you like to provide any final comments?
Sure.
Thanks.
And Madam Chair, I appreciate concerns that this doesn't solve all the problems in the healthcare system. We have more to do, and I want to do more than this. But I think when we look at the hassles, I mean, we've, as Senator Portman mentioned, we've had 4 decades of this stuff that we're going to set up these new administrative procedures that are somehow going to save money so people aren't overusing healthcare. And we've done 4 years of putting barriers to care by making sure people don't get their choice right away and they don't get the things their doctors prescribe, and that prior authorization, where, as several people of both parties have mentioned, people who have never seen the patient, many of whom don't have medical training, are making decisions on what the appropriate care for those patients are. And in the end, all these 4 decades of saving money have left us with literally twice as much per person in healthcare spending is all but about twice or more as much per person as all but about 10 or 12 other countries on the planet have, and much worse outcomes. And to me, the idea that we might save, as Mr. Talman said they did in Connecticut, is improving care for the patients, improving the lives of providers and making them happier and more willing to participate, and saving 14% in the process is pretty significant, because again, 14% of $20 billion a year is a lot of money. So I very much hope so. We are waiting for a fiscal note, and we'll keep you posted on that, because I would love to have this continue to move forward. So,
Great.
Thank you.
Thank you, Senator Marty. Thank you for your testifiers. And Senate File 3612, as amended, is laid over. And now we will move to Senator Mann, Senate File 2939. Senator Mann, this bill, we had informational discussion last year. I believe there is a A1 amendment, or, okay. And that is being distributed. Did you want to touch on the A1 again? It was brought forward last year when we had the discussion, but if you could discuss that just briefly, and then we can move to adopt it.
Thank you, Madam Chair. Yeah, it just puts in the corporate practice of medicine piece in Article 2 that ensures that when entities own or invest in healthcare practices, they don't control or interfere with the actual medicine that is provided. And again, it was the same one we heard last year.
Thank you. And Senator Mann offers the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 is adopted. Senator Mann.
Thank you, Madam Chair. Senate File 2939 is a bill to rein in the corporate practice of medicine and private equity buyout of our healthcare system. It does 2 things. Article 1 addresses gaps in transparency around ownership and financing of current health systems. This ensures that we see the relationships within our increasingly complex, vertically and horizontally integrated healthcare systems. For example, it is in these relationships between different owned and contracted entities that private equity has managed to extract wealth from nursing homes and from our health systems across the country. And we want to see what that looks like in Minnesota. And then Article 2, I just mentioned, ensures that entities that own or invest in healthcare practices, they don't control or interfere with the actual clinical decisions that are being made. Minnesota prohibits this kind of corporate practice of medicine, as do most states, but our prohibition comes largely from case law. So this bill gives corporate practice of medicine its own section and clarifies protections against modern abuses, such as setting quotas or limiting on certain diagnoses and services, or limiting the amount of time a provider can spend with their patient. With that, Madam Chair, I will turn it over to the testifiers. Our first one will go into what is happening with private equity in the healthcare space and why this legislation is important for the safety of our patients and how it is directly related to the increasing costs in our healthcare system.
Thank you. And Dr. Singh, I believe you are on Zoom, and if you could unmute and state your name for the record and begin. And members, the presentation that the slides she's sharing have been distributed to the committee. Thank you.
Good morning. My name is Yashaswini Singh. I'm a healthcare economist by training and an assistant professor at Brown University at the School of Public Health. I appreciate the opportunity to testify before you today to provide a background and overview of private equity investments in healthcare. Private equity investments in healthcare in the US have skyrocketed over the last 2 decades. Investors have poured in over $1 trillion in the American healthcare sector in over the last 2 decades. The investments in the early 2000s targeted institutional facilities like nursing homes and hospitals. Starting in about 2015, 2016, the investment focus has shifted towards outpatient settings of care, such as physician offices and ambulatory surgery centers. I thought it might be helpful to provide an overview of what specific defining features differentiate private equity investments from other types of private or for-profit investments in healthcare. First, the incentive structure of PE relies on large amounts of debt and a desire to make short-term returns over relatively quick investment horizons. PE firms generally finance the deal with 60 to 90% of debt. They are seeking to exit investments within 3 to 7 years, and they often target high rates of internal return, upwards of 20%. These incentive structures often emphasize rapid value creation over long-term investments in the quality of care or care continuity or other measures that are in the interest of patients and healthcare workers. As we will hear today, PE firms, because they are private in nature, these are private investors that invest in other private entities. They face very limited reporting or disclosure requirements. This makes it very difficult to know who the ultimate parent owner is of a healthcare entity that is shaping the care patients receive. It also makes it difficult for researchers, policymakers, and other stakeholders to understand the invisible forces that are shaping the healthcare we receive. I also wanted to flag that PE investments are distinct across settings, and so it is worthy to consider. PE generally accompanies rapid consolidation in the outpatient setting, where investors follow a platform and add-on model of growth to consolidate markets. But in other institutional settings, such as hospitals and nursing homes, private equity investors are known to separate the property company from the operating company, essentially leasing back the real estate that an entity previously owned, which can create significant financial pressures and has led to bankruptcies and closures of hospitals and nursing homes. I also wanted to provide an illustrative example of why ownership transparency is critical to understand the ways PE is reshaping the American healthcare system. As a brief overview, we consider PE firms that raise capital from institutional investors, such as pension funds, sovereign wealth funds, and university endowments. This capital is then combined with large amounts of debt, such as upwards of 60 to 90%, to create a PE fund, which is the investment vehicle used to make a majority stake investment in a platform practice. In this illustrative example, the platform practice is a physician group of 3 physicians. Depending on the corporate practice of medicine, doctrine, and estate, firms might rely on management services organization as well. Importantly, the platform and add-on model of consolidation means that each subsequent acquisition is not reportable, even though cumulatively they can all reshape healthcare markets. So in this illustrative example, the initial platform acquisition of 3 physicians is followed by an add-on acquisition of practice A with 2 physicians, practice B of a solo practitioner, and practice C of 4 physicians, giving the PE firm very quickly control over 10 physicians in the market, even though each individual acquisition was not reportable or disclosed. This type of consolidation also offers investors to capitalize on efficiencies, such as those gained through economies of scale, particularly for back-end administrative and support functions in running a practice. But most importantly, from the investor standpoint, it offers the investor to exit the investment for a higher valuation over a relatively short time period. Theoretically, investors can exit via taking the practice public via an IPO, selling to non-PE buyers in the market, or simply flipping the practice to another PE firm. My research has shown to date that exits generally take the form of sales to other PE firms, essentially restarting the cycle of buying to sell. I like to share this slide with us to illustrate how PE investment in physician practice might operate, but also to highlight that no part of what is illustrated on this slide, neither the initial investment nor the subsequent exit, is reported in any form or nature to any regulatory body, either at the federal or state level. I also wanted to provide an overview of what the research evidence shows about the effects of these investments in healthcare. Theoretically, there are benefits that can arise from private investments, such as capital infusions that can improve the efficiency of care. But practically, the empirical evidence does not show too much support for these purported benefits. Rather, we've seen that PE investments increase the cost of care in the ballpark of 10 to 26%, depending on the specific clinical area examined. This is often accompanied by increases to utilization as ancillary services such as lab tests and imaging services increase following acquisition as well. Investors often also bring about changes to workforce composition and staffing by increasing a reliance on advanced practice providers, and we see a higher incidence of physician turnover, perhaps reflecting overall discontentment and dissatisfaction with the performance-oriented nature of changes that are brought about by investments. In the nursing home and hospital setting, we have some quite concerning evidence showing that investments lead to adverse patient outcomes such as falls and also mortality in the nursing home setting. Although evidence on quality outcomes in outpatient settings is quite mixed, overall the evidence suggests that the cost of care increases with marginal, if any, changes to the quality of care in the best case settings. I also wanted to highlight in Minnesota in particular, investors have been drawn towards opioid treatment programs or methadone clinics. As we likely know, methadone clinics or OTPs are the only licensed setting that can dispense methadone, a critical medication for combating the opioid epidemic. We see that in Minnesota in particular, 20% of opioid treatment programs are affiliated with private equity firms. Nationally, this estimate is around 1/3. And then national data also tells us that this does not correlate with any improved access to medication or improved access to facilities that can provide these medications, questioning what role or what value these private investments are bringing to opioid addiction treatment. I also wanted to summarize some information that is presented by the Private Equity Stakeholder Project, a consumer advocacy organization that I serve on the advisory council for. The Private Equity Stakeholder Project has a metric called the Private Equity Risk Index across various states, and they try to ballpark a risk score for each state in the U.S. Minnesota at present is classified as being exposed to medium risk given our current understanding of PE investments in healthcare, but as we've discussed today, these estimates are largely underestimates given the lack of transparency and reporting. And so with that, if we try to estimate private equity's footprint in the state, at best, our guesses are around 20% for opioid treatment programs. So 20% of OTPs are PE affiliated. But if we try to estimate similar estimates for hospitals or nursing homes or physician practices, we are severely inhibited by the lack of systematic data or reporting requirements that help us understand these increasingly complex and hierarchical ownership structures. So in sum, I'll just say that our state-specific evidence, a lot of the data we have so far is national in scope. State-specific evidence is severely restricted by the lack of the types of data that we've been talking about today. And of course, the regulatory challenge is in ensuring the balance for capital investments with safeguards for patients and healthcare workers. I thank you for your time and the opportunity to testify before you today.
Thank you very much. Next, we'll go to your other testifiers, Senator Mann, Stu Laurie, and Dr. Bruce Bostrom. Welcome to the committee. If you can state your name for the record and begin.
Thank you, Chair Wickland, members of the committee. For the record, my name is Stu Laurie, Government Relations Director for Minnesota Farmers Union. We'd intended to have a member here this morning to share some of her experience with you. Unfortunately, her schedule changed and she couldn't be here. So I'm glad to share some of our perspective, our support for Senator Mann's bill, and also part of Dana's story. So, Farmers Union, grassroots general farm organization founded in Minnesota in 1918. Fundamentally, I understand that we exist to make life easier future for family farmers in rural communities, help them earn a fair living for the work that they do to produce the products that we all rely on. And what's been made abundantly clear to me in my years with Farmers Union, even more clear this year, is that healthcare is a principal impediment to building a good life in rural Minnesota. As our members describe it, they're experiencing two interrelated challenges, both of which are familiar to this committee. Healthcare costs are increasing for them as much as 20% on the individual market. Costs are increasing when they go to seek care. They're also seeing decreased access and an increasing impersonalization of care as clinics close, as systems consolidate, and as decisions move further away from their healthcare providers, as we've discussed today. These challenges have prompted our organization to dig into the role of private equity, consolidation, vertical integration in our healthcare system, understanding that all those factors serve to increase costs and often lead to decreased services in rural Minnesota. So just one example that our testifier would have shared, Dana Seifert is a physical therapist. In addition to her role on her family's farm, an organization that she worked for, she was caring for two patients in that job. The first patient was improving well, meeting her care goals, ready for discharge. The patient shared with her and her team that actually they didn't want to be discharged because their kitchen was getting remodeled and they'd rather stay an inpatient for a couple more days. Dana shared, this wasn't medically necessary. Her manager told her, no, this is a preferred patient. They have good insurance. They can stick around for another couple days. A second patient was not progressing the way they should have. They had stairs to get into their home. She was confident they wouldn't be able to climb those stairs. She said, hey, we need to keep them inpatient for longer. Their manager said, no, they don't have good insurance. We're not able to keep them. You need to discharge that patient. Just one example of what our members are well familiar with as patients and folks seeking care is that there are great inequities that are created as decisions move further away from the healthcare professionals who are charged with folks' care. So we appreciate Senator Mann's hard work on this. We appreciate this committee's attention and are glad to share our support. Thank you.
Thank you. And Dr. Bostrom, if you could please state your name for the record and begin.
My name is Bruce Bostrom. I want to thank you, Chair Wickland, and Senator Mann for inviting me to speak in support of the bill. I am a retired pediatric oncologist. I spent 40 years working in this state treating children with cancer and blood disorders, both at the University of Minnesota and at Minnesota Children's. And I was never in private practice. I was always an employee of those institutions. And over 40 years, I've seen how healthcare has become more and more consolidated. And I would say that consolidation is not necessarily bad. But I've seen modernization improve healthcare in ways such as integrating patient data. However, I believe that this improvement is not due to integration, but due to the use of electronic medical records, which pulled more medical information and sharing of medical information that improved the healthcare and the lives of the professionals that deliver it. As an example of a good consolidated institution, we have in this state our own Mayo Clinic. It's a renowned, massive integrated healthcare system. And one of the founders, Dr. Will Mayo, has a famous statement that says, "The needs of the patient are the only needs to be considered." There is a conflict that must be acknowledged between and dealt with the needs of the venture capitalists, which are in conflict or may be in conflict with the needs of the patient. Fewer and fewer corporations control more hospitals and clinics in Minnesota. Healthcare consolidation leads to price increases up to 65% in one study. Private equity takeovers of healthcare lead up to 32% higher costs. But as was mentioned, wages are not going up that much and reimbursement not going up that much for those in private practice. This unfortunately means that patients must forego necessities to pay for the health care when issues come up for them, and or delay care because they don't have the wherewithal to pay for the care. Minnesota has already taken important strength to strengthen oversight in healthcare mergers, but we need more transparency around the cooperation, around corporate ownership and influence in healthcare, and how patients and physicians and what tools we can use to help rein in costs. I urge you to pass this legislation without delay, as costs are continuing to climb, and patients are only to suffer delay care more. You have an opportunity to ensure Minnesotans can better afford and access quality care in the state, and thank you. And in addition, I'd like to say I really appreciate the testimony of the two senators who have had real experience with their own family, they and their own family. I have seen that so many times, and it's real, and it's getting worse. So thank you, and I'll be happy to answer any questions.
Thank you very much. Members, do you have questions or comments about the bill? Senator Curran.
Madam Chair, I think just looking at a comment, so Prairie Care is one of the nation's largest providers of mental health services, and they say that this bill will be a substantial administrative burden. And so we just talked about, and the burden will, again, from an administrative perspective, remove resources from the front line providing care. And so we just heard a bill about the burden of going to a government-run system to eliminate the burdens and the intrusion. And here, this bill is doing the exact opposite of the conversation we just had. So again, it just doesn't seem to make sense when we've continually imposed those burdens that continually impact these systems and put the strains on every business, and thus the acquisitions, and try to consolidate all those activities occur. It just seems contrary to what we just had a conversation about. Thank you.
Senator Mann.
Thank you, Madam Chair. Thank you, Senator. So we've heard that a lot from different organizations, and that is something that we can certainly decrease what's required. But I will point out right now in the bill, the vast majority of the reporting requirements are basic identifying information, and the rest of it is like an organizational chart showing subsidiaries and affiliates. And if you're saying that your organization cannot do that because it would be such a substantial administrative burden to write down who you're affiliated with, I think we should all be very concerned about that, Madam Chair, and probably a little suspicious, too, about what's going on, that they cannot provide that information.
Any other questions, comments? I don't see any others wishing to speak. I would like to express my thanks for your bringing this bill forward. I think it is an area that we need to get at more transparency, more information for Minnesotans. I think I have concerns that the work or the transitions that are going on with private equity, making purchases, as your testifier stated, it has been shown to increase prices for people, but not adding value for them. I think we need to be concerned about what the changes are happening, and the amount of resources that are going to purchase, entities that had been provided by other entities like hospitals, maybe had been providing some of these services. And I'm concerned that it might change the way resources are distributed, which could affect the public in terms of how some of these entities like hospitals have been providing what we would call kind of public good services. So shifting these resources to a place where the public isn't receiving a benefit and we are seeing increased costs seems like a detrimental thing. So I hope that your bill can continue to move forward. and that we can increase the amount of information available to the public about these entities. This bill needs to move to the State Government Committee, and would you like to make the motion?
Yes.
Senator Mann moves that Senate File 2939 as amended be recommended to pass and be referred to the Committee on State Government. Members, any other questions? All those in favor of the motion, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 2939 as amended is referred to the Committee on State Government. Thank you. And now we will move to Senator Mohamed. Senate File 2621. Welcome to the committee, Senator Mohamed. And if you would like to present your bill, we are receiving an amendment, and you can talk about the amendment and then we can have discussion about it. This is the second committee for this bill, so we'll have a discussion and you can tell us how it affects your bill, and then we can move the amendment. Senator Mohamed.
Thank you, Madam Chair. I believe the amendment came from council.
Ms. Hoffman-Litchi.
Madam Chair, members of the committee, the amendment just adds the committee with jurisdiction over homelessness to who receives the report under the Council on Community and Household Stability Council. So.
Members, do you have any questions about the amendment? Sounds like it makes the bill more, it is not a substantial amendment. Any questions about the amendment? Okay, Senator Mann moves the A3 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Mohamed.
Thank you, Madam Chair and members of the committee. This is Senate File 2621. We know the challenges and the statistics, the high costs to build and sustain housing, the shortage of 100,000 affordable units, that almost 650,000 Minnesotans pay more for rent and mortgage than they can afford. That's where we were last session when we discussed this bill in the Housing Committee. And that was bad enough. But let's ground ourselves in the moment. Since December, Operation Metro Surge has terrorized communities, ruined local economies, and bankrupted small businesses and forced Minnesotans into hiding and out of work. In Minneapolis alone, economic losses run well into the hundreds of millions of dollars in missing wages, in a city with 35,000 households struggling to make rent before Operation Metro Surge. As we know, Operation Metro Surge has had a direct or ripple effect across the state, from Wilmer to Rochester, St. Cloud to St. Paul. We should keep that in mind as we consider the present of our housing crisis. We cannot continue to rely on short-term, one-time funding if we are to truly take on the housing challenge. We are stuck in a cycle of emergencies, and we need a long-term solution that addresses the root causes. This bill, Senate File 2621, before you is a constitutional amendment for dedicated revenue for housing, a sales tax of 3/8% estimated to generate $400 million annually over 25 years. For 25 years. That's transformational amount of predictable funding that will end emergencies, makes it possible to plan our way out of this crisis. This bill creates 3 funds for distribution: a home ownership opportunity fund, a rental opportunity fund, and a household community stability fund. In Minnesota, we prioritize what's important. We dedicate funding to transportation, to health care, and to natural resources. Housing should be next. A stable home is essential to a stable life. This amendment puts the decision in the hands of the people to affirm that our future starts at home. That is all I had for remarks, Madam Chair, and we'll take that.
Thank you. Yeah, we can move to testifiers. I forgot to mention, I did mention that the bill has been in another committee, but I wanted to mention that the parts of the bill that are within this committee's jurisdiction, it's Article 2, Sections 1 and 2. So that's our main focus in here, and just want to make sure people were aware of that. And now we'll go to testifiers. And Ms. Nalima Sitati Monene, I'm sorry if I mispronounce your name. If you could please state your name for the record and begin.
That's all right. Thank you, Chair Wickland. Thank you, committee members. My name is Nalima Sitati Monene. I'm the Executive Director of ACER, the African Career Education and Resources, Inc. We're an issue-based organization in Minnesota. I'm also one of the co-chairs of the Opportunity First Starts at Home campaign coalition. The Opportunity First Starts at Home, we're a coalition of over 80 organizations across the state of Minnesota who have come together to address the lack of a permanent resource for housing in Minnesota. We believe this is a very important issue, and it is important that we address the long-term housing issues that we have been dealing with for a long time in Minnesota. So for a long time, we have known what works. But what has been happening is that either we're not funding the solutions, or when we do fund the solutions, they are either temporary, short-term, or we're not funding the permanent solutions at the scale that is required to either resolve the issue or at least make a difference. So what SF 2621 does, it proposes 4 buckets of funding, and this is how the distribution of the funding would look like. 25% for household and community stability, and we have 2 buckets that will address the rental opportunity. One would be 25% for rental assistance and 25% for Bring It Home Minnesota, and finally 25% for home ownership opportunities. What does that look like in numbers? Over 25 years, we could add 28,500 new rental units or preserve 200,000 of existing rental units. Over 25 years, we could add 25,000 new starter homes or finance 50,000 new home buyers. This is important because the data tells us that currently the average age of a first-time home buyer is 40 years of age. That means that many young people and many young families are being left out of the opportunity to purchase homes. In my community in the northwest suburbs, cities are beginning to pass ordinances to limit rentals in their communities for single-family homes because they know that young people are being locked out of the opportunity, and we know we need young people in our cities. This constitutional amendment is one part of a larger housing vision that includes appropriations, bonding, and policy changes, as well as local investment, federal funding, and policy and private partnership. The high housing costs in form of rent increases, poor quality rental housing, and lack of starter homes, all of these things are already a housing tax that these people are hardest hit, who are service workers, people who work in restaurants, retail, home health care, and more. What this would look like, for example, will be for one of our resident leaders in my community, Ms. Sharon, who has lived in the community for over 60 years and worked in the school district and currently lives in a rental housing. But every year her rent keeps increasing, and she's on a limited income with her husband. And every year we have to find solutions for her to continue to remain in her rental unit. Increasing the resources available for housing will ensure that people can continue to live in their own communities where they are contributing members even after retirement. Thank you.
Thank you, and welcome to the committee. And if you could please state your name for the record and begin.
Thank you, Madam Chair and members of the committee. My name is Ben Helvig Anderson, and I'm the Vice President of Beacon Interfaith Housing Collaborative and a fellow co-chair of Our Future Starts with Home. Beacon operates more than 1,200 units of housing, is one of the largest supportive housing providers in the state, and also a collaborative of over 70 congregations. In Minnesota, we have been a national leader in creating an effective homeless response system built on proven solutions to homelessness, such as supportive housing. Supportive housing is a permanent home paired with wraparound services people need to stay stable and healthy. Supportive housing works and is transforming lives daily, yet our system is fragile because of the fragmented, often one-time nature of funding, which prevents us from ever growing to the scale of community need. To serve Minnesotans best, we need dedicated, reliable revenue for the homelessness response system, which this amendment would provide through the Community and Household Stability Fund. 2 weeks ago, Sasha, a Beacon supportive housing resident from Plymouth, was here speaking and said, "Living in this supportive environment has changed everything for my family. I've seen kids grow in new ways. Being together in our safe place has meant all of us have been able to eat meals together, confront the challenges of our past, and heal for a brighter future." Our Future Starts at Home would create 4,400 new supportive housing units for families like Sasha over the next 25 years, while also stabilizing services and operations at current and new homes. This is just one example referenced in this handout of the differences this bill would make to ending homelessness in Minnesota. Minnesota is a leader in homelessness response, but our next transformational step is consistent, ongoing resources that will only happen through dedicated revenue. Our future starts with home. Thank you.
Thank you. Dakota Morgan, if you could please state your name for the record and begin.
Thank you, Madam Chair and members of the committee for this opportunity. My name is Dakota Morgan. I'm a policy fellow with Minnesota Coalition for the Homeless, a youth leader in the Ramsey County Continuum of Care, and a program advocate with Listening House of St. Paul. I also bring a lived experience of homelessness after foster care, which shapes both my work and the perspective I bring to this conversation today. I'm here in support of the Our Future Starts at Home Act, specifically the Household and Community Stability Fund. Over the years, advocates, service providers, and community members across Minnesota have participated in countless listening sessions and planning conversations about how to address homelessness. What we hear again and again is the many barriers organizations face, and many of the gaps families fall through come down to one core issue: the lack of flexible, dedicated funding that allows communities to respond to real needs in real time. When we talk about ending homelessness, we're not claiming that no one will ever lose their housing again. Experts often define ending homelessness as making it rare, brief, and non-reoccurring. Life circumstances such as job loss, illness, family conflict, or domestic violence can still lead people into temporary housing stability. But as a state, we have a responsibility to ensure that temporary hardship does not become long-term and permanent homelessness. That is where the Household and Community Stability Fund becomes so important. If Minnesota truly wants to end homelessness, we must invest in the entire continuum of support while we work toward the ultimate solution, ensuring there is enough affordable housing for everyone. While we work toward that long-term goal, communities need the resources to stabilize households quickly, prevent evictions, support people exiting institutions. That is where my own experience illustrates this gap. Young people leaving foster care represent one of the most predictable pathways into homelessness. We know the risks. Yet programs designed to support young people transitioning out of foster care remain vastly underfunded, limiting the ability of communities to connect them with the housing stability supports that they need. The dedicated resources through the Household and Community Stability Fund would allow communities to better integrate these young people into the existing prevention and stabilization programs. Another lesson organizations across Minnesota have learned is that individuals with lived experience hold critical knowledge about what actually works. The Our Future Starts at Home Act reflects these values by creating structures where those with lived experience help guide decisions through advisory councils and collaborative planning. I urge you to support the Our Future Starts at Home Act and the Household and Community Stability Fund. Thank you for your time and consideration.
Thank you very much for your testimony. Members, do you have questions or comments about the bill? Senator Liskey.
Thank you, Madam Chair. Madam Chair, I'd like to offer the A2 amendment.
Senator Liskey offers the A2 amendment, which will be passed out. Senator Liskey, do you want to start talking about it?
Sure, Madam Chair. While we're also waiting for it to be passed out, I'd also like to ask for a roll call, and under Senate Rule 12.10, have that roll call be recorded in the Senate Journal.
And are there 3 hands? I think I need. Okay, 3 hands being seen. The roll call will be recorded. Senator Liskey.
Thank you, Madam Chair. As a representative of one of the suburban, or in this case, metro area counties, specifically Dakota County. This amendment is designed to avoid duplicative tax on those members that live within the metro. Currently, the way the bill is written, the already existing sales tax on the metro counties at 0.25% would be still in place, which would mean that they'd be paying double the tax for the same purpose. And so with that, with this amendment, that would remove that on passage of the constitutional amendment.
Senator Mohamed.
Thank you, Madam Chair, and thank you, Senator Liskey, for this amendment. It's an amendment we heard in housing. And I'll first touch on the fact that the metro sales tax, which we passed in '23, is implemented and is working well. And just in Hennepin County, we avoided 1,270 evictions because we did that. It is also important to note that other parts of the state were left out of that metro sales tax. The goal of this bill is to not double tax people. It's intended to have one tax across the state. So if this does pass, we can revisit that conversation. But for now, we want to keep as it is.
Senator Port.
Thank you, Madam Chair. Thank you, Senator Mohamed, for bringing this bill. To this amendment, I think, what I would say is it is working well right now. I have not heard from any cities or counties that they would like to stop receiving that money that we're raising through the metro sales tax. I think the need exists. It is certainly, I agree with you, something we should keep an eye on, but I would, support the author's wish for a no vote.
Other discussion on the amendment? No? Senator Liskey, did you?
Thank you, Madam Chair. To address that, again, this amendment wouldn't go in effect until after the constitutional amendment were passed. So technically speaking, what you just said was we would readdress the duplicative tax after passage. This would take care of it so we wouldn't have to go through the process again when we do, when we do pass the amendment as a constitutional amendment. It doesn't change anything now. It doesn't take away the tax. Like Senator Port alluded that it would take away the tax now. It doesn't. But it would take it away after passage of the constitutional amendment. So I urge a yes vote, as it doesn't actually change anything until the bill were to pass and the amendment were to pass. So thank you.
All right. Are members clear on the amendment or have any other questions? Otherwise, Ms. Ryan will take the roll.
Chair Wicklund,
No.
Vice Chair Mann, Lead Utke,
Yes.
Senator Abler, Senator Bolden,
No.
Senator Fate,
No.
Senator Cran,
Yes.
Senator Kupek,
Nope.
Senator Liskey,
Yes.
Senator Port.
No.
There being 3 yes votes and 6 no votes, and 1 member absent, the motion does not prevail and the A2 amendment is not adopted. Excuse me, Senator Port.
Thank you, Madam Chair. Senator Mohamed, again, thank you for your work on this over multiple years. I know this has been an evolving conversation as we more clearly understand not just that we need dedicated funding, which I think has not been in dispute this whole time, but how we can best deliver that dedicated funding and ensure that it is connecting to the needs of all of our communities. And I really think, particular to this committee's jurisdiction, in Article 2, these changes or this part about Community and Household Stability Council is so important to have those connections to what is actually happening in people's real lives. I particularly appreciate a member representing the Council on Disability. I think that's an incredibly important part of housing that we often don't think about as a core piece of it. And I really appreciate that you have that
in these councils. I think that's a really important piece. I think this is really thoughtful. It looks at the continuum of housing care, which we know there's a lack of funding across all of it. So I am really grateful for your work on this bill. I look forward to continue voting yes for it. And I think this could have a massive impact on the state of housing and people's ability to have stable housing in Minnesota. So thank you.
Members, any other questions or comments? Senator Liskey.
Thank you, Madam Chair. I just want to make a request for keeping a roll call on this and putting it on the journal as well under Rule 12.10.
And I think, I requested the 3 hands, and that was to,
So it'll be on the bill, not just because that was for the amendment.
oh, I'm sorry.
Yep,
I'm sorry, I
I just
misunderstood.
have to make 2 motions,
All right.
unfortunately, so
Okay.
thank you.
And so on your motion for a roll call and to be recorded in the journal, I see 3 hands, and that will be the case then. Any other questions or comments? Senator Udke.
Thank you, Madam Chair. And as I'm looking through this, and I think this actually falls into section we get, because I think I believe you said it was, Article 1, Section 1, or Article 2, Section 1 is ours. And it talks about the funding, and I'm on number 5 to be exact. It talks about financing the acquisition. To me, I don't know, I've been looking at that and trying to figure out, financing seems like it should mean we're borrowing the money. We're not borrowing the money. It's more we're funding the acquisition. But that's a minor thing. But my concern over this whole thing is, we've seen this years back when we thought we were helping people. We got them into home ownership with, in most cases, nothing down. If they don't have enough money to invest in it somewhat on the front end, we see that they fail because they can't make the payments that it takes, the insurance and taxes and the maintenance and the upkeep and all these things. I'm just afraid this is just one more idea that is setting people up to fail. And so that's my concern. I don't think we should be doing this in the first place. We got people that work really hard. Home ownership is something everybody strives for. It's for most people, it's the biggest asset they will ever own, and that's wonderful. It's a great goal for everybody is to own your home. But I don't think this is the way we do it. Somehow we have to figure out a system that actually lets them earn enough money to do it the conventional way so that when they step up and buy a home, they're able to keep it going. And we don't need any more crashes of 2008, and we can go back in time, and we've seen this repeat itself many times. So that's my concern, but thank you.
Senator Mohamed, did you wish to make a comment?
The only thing I would say, Madam Chair and Senator Udke, is that this bill is comprehensive. It touches on home ownership, but it also, in the article you talked about, Article 2, the reason why it's in this committee is because it touches on emergency assistance to households who are experiencing or at risk of homelessness, legal support for those folks. It also includes building more housing. So I think it's comprehensive, not just for folks who need to own a home, but people who are struggling with homelessness, building more housing for, more money for people who want to build more housing. And so that's the only thing I would add. But yeah, I think people need to be set up for success when they want to own a home. And I think 2 years ago we did the home ownership fund, which has been really successful. Probably one of the most successful things that we did in housing, and so many more people in our state are homeowners because we invested in that money and have not foreclosed. We haven't heard any of those cases. So.
Senator Port.
Thank you, Madam Chair. I'm sorry, I just have to respond to that. We, as Senator Mohamed said, we have had incredible success funding, investing in down payment assistance programs. We have an incredibly low default rate. They are allowing people who do not have that down payment money to invest. Unlike our parents or grandparents' generations, you can't buy a house for $67,000, and you can't pay for college by working a summer job. That's just not the reality of the world anymore. I think, as one of our testifiers said, the average age of a first-time homebuyer is now 40 years old. That is an insane number, insane. That is not how any generation before us has been able to work into homeownership. I think if, folks across the aisle want to author a bill to end income inequality and raise wages, we would probably support that too. Because wages have drastically decreased as the cost of everything has continued to go up. People cannot afford a down payment anymore. They cannot afford rent anymore. It has become a capitalist, money-making scheme, and regular people cannot afford housing because of it. Private equity is part of that problem, but this is widespread, and the federal government has defunded these programs consistently over the last 50, 60 years, and the state has not been able to fill that gap. We simply can't. But this is a step at dedicated funding. For the most part, the housing budget is between $15 and $50 million a biennium. That is nowhere near the amount of investment that we need to stably house our neighbors. This is a great step forward. I appreciate that. But I think it is important to remember that, like, when we have had housing crashes in the past, it is because of malpractice by large corporate banks who took advantage of people. It was not because the state invested money and people decided they didn't have to work anymore and could just get free housing. That's not what happened. It was because banks were preying on people, took advantage of them, and then the bubble burst and hundreds of thousands of people lost their homes. This is investing in that. It is not stripping the wealth from our communities, and I think that is a very important distinction.
Members, any other questions or comments about the bill? Seeing none, Senator Mohamed, thank you for bringing the bill forward. I think in our committee, we have more discussions about how to address the, emergency needs, emergency housing, and trying to help people who are in a situation of homelessness. And we know that that's one aspect, and I appreciate that this bill will take steps to address that, along with the whole, the continuum of needs outside of that as well. So I appreciate your bringing this forward. This bill will also be referred to the Committee on State Government. If there are no other questions, I will, on the motion of Senator Mann, that Senate File 2621 as amended be recommended to pass and be referred to the Committee on State Government, and Ms. Ryan will take the roll.
Chair Wicklund?
Yes.
Vice Chair Mann? Yes. Lee Dutke?
No.
Senator Abler? Senator Bolden?
Aye.
Senator Fateh?
Yes.
Senator Curran? Senator Kupek?
Yes.
Senator Liskey?
No.
Senator Port?
Yes.
Seeing that there are 6 votes in favor and 2 votes opposed, the motion does prevail, and Senate File 2621 as amended is passed and referred to the Committee on State Government. Thank you. And with that, seeing no other business before us, we are adjourned.